medications and this and that back and forth. Block 2, we will get into those benign things, right? So we're going to talk about BCC, SCC. We're going to talk about all of the diagnoses that are out there. And then block 3, that's when we're going to get into the bad stuff, the life-threatening stuff, right? So we're going to get into melanomas and this and that and yada yada. Half of block 3 is basically rheumatology. I don't like rheumatology. I don't like how we're going to talk about lupus and we're going to talk about Sjogren's. We're going to talk about other things like that. Am I going to test on that stuff? Yes, but it's not as much as what is going to be built with all of the cancer stuff, okay? Again, y'all can see that we have 6 days before of a test. I lecture in the first 5, and I'm a quick one, okay? I lecture on the first 5 days, and the 6th day is simply us sitting down and me reviewing the entire thing so that we can make sure that I've said and showed everything that I'm going to test you on, okay? So that is how I do this when it comes to that. What else? Oh, you can see once you actually download or you have access to of our slides, you'll see that the PowerPoints are about like 80 slides, 100 slides, depending on what it is. Half of those slides in every lecture are pictures. We have pictures and pictures and pictures that I'm going to be showing y'all, okay? Half of your test is going to have a picture. It's not going to be a picture that is in these slides, but it's similar to it. It looks almost exactly like it does. So with dermatology, that's you looking at stuff. Yes, you're going to touch some stuff and you're going to feel some stuff, but just looking at it is going to set you of a differential diagnosis of what you think that it would be. So pictures are a lot of these things that are in there. Again, it's not just of a picture and I say, what is that? You know, that type of stuff. There's always that of a question that puts, you know, some of the terminology on there, that stuff of hints and signs and symptoms and this and that that are all out there, okay? Again, I go through slide decks and that is the key, okay? The best part, I don't know if any of y'all have heard yet, but 24-3, right before y'all, are the first class that is not going to be taking a phase 2 derm test. They are not doing tests now on derm, ENT, and ortho. They're still going to go through those rotations, but now they do not have to take the test. So I don't have to do it anymore, and I'm happy with that. That will then be for y'all. The other thing that y'all might know or might not know is that now y'all are doing all of those tests on those other the areas, right? So family practice, internal medicine, pediatrics, you know, da 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 da. But now y'all are taking tests from PAEA. So those are big tests. They're actually 120 questions per test that y'all are going to be doing. So you're not going to get derm, you're not going to get ENT, you're not going to get ortho, still going to do those rotations, but you're going to still have derm stuff in family practice, in internal medicine tests, and all of those other things. It'll still be out there. So you'll have less than 3 tests, but it's kind of, they've upped it now to where y'all are taking more tests because it's 120 questions per each of those things. So, yay, nay, it's up to you. Okay. All right, so let's get started. This right here is the very first lecture, and this is just basically going through some of the AMP1, right? I'm going to talk about some of the treatments. I'm going to talk about these things. Again, there will be some of these questions on the test, but it'll be of a breakdown. So I'm going to go through these things, and we're going to talk, and then next we'll take a quick break, and then I'll jump into 40-something slides of steroids. So, I'll stand over here, Ben. Again, there you go. What I just said. You know that in of the syllabus, I have to list multiple references that will show some of these things. So in there is Fitzpatrick, okay? Fitzpatrick, no. Habib is the Bible, okay? All of the questions and of the answers are in Habib. Habib is the Bible of dermatology. So that is the one that we will reference and look at and see all of those things. Okay, skin disease. Y'all went through all of this stuff back in your freshman semester. So a year ago, y'all were going through this stuff. I don't have to get into all of that because y'all know we have epidermis, dermis, below, you know, all of those areas where that stuff is at. We will talk about where these disorders can occur at, okay? Again, we know that those 5 layers of the epidermis, so corneum is on top, that's the top of the base, or the skin, and then it breaks it down, you know, through those areas there. 5 layers. 5 layers, okay? Again, picture showing those things there. Of course, we know that all of the diagnosis of skin disease has to be proper. It has to be, whether it's some type of pathology, whether it's some type of a biopsy, whether we're doing some things, we have to get that diagnosis officially set aside so that we can then treat and go that way. Approach. Skin disease, right? We always, y'all have all done OSCE numerous times. Y'all have written soap notes, so you know we always ask about their medical history. We talk about their family history. Did your dad have prostate cancer? Did your dad have this? Your mom, brother, sister? We always ask those things, okay? When we're doing that the physical exam after that interview, we're looking at the phototype, distribution. Is it a one lesion or is it generalized? Is it over, you know, not just one area, but it's in multiple spots because of the spreading that is occurring? Of course, we always have differential diagnosis, so this could be this or this, but I'm pretty sure it's this because bum, 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 okay? So that's there. Again, y'all know all about the history, allergies, medications, family, social, right? We're going to be getting into some of that STI stuff, right? So we're going to have to know, hey, did you have sexual activity with an individual? How was it done? What is this? What is that? Is that person having symptoms like this as well? So of course, y'all know about all of this stuff here. Specifically for dermatology, that's when we ask for these other things, right? If they're coming in because they sprained their ankle, I don't need to know if they used any perfume on it, no. But if they've got something going on with their skin, if they're having some type of a manifestation, then yes. What is the soaps, shampoos, perfumes, makeup, deodorant? What are you washing your clothes with? What is your job, right? We're going to get into some of these disorders that occur specifically if you're a hand washer, if you are a farmer, if you are construction, if you're in those areas where you can be exposed to something that would then lead into these things. So that's part of stuff specific for dermatology. Again, I talked about the Fitzpatrick book. This is not talking about the book, it's just the same thing. So there's something out there that we are going to learn that is called of a Fitzpatrick skin phototype. So basically, what color are you, right? Are you a 1, which is of a Rory McIlroy, okay? It's Ireland. It's some type of a ginger. That's of a 1. Whereas if we're jumping into Usain Bolt, something, right? That's all the way down on a 7, so that's a dark pigmented person, and then you just calculate through that. Again, we're going to go through those things and break them down. Yeah, we're going to talk about those things. Okay? Description, number. Is it actually one spot, or is there numerous stuff that's on of the upper chest, or on of the right shoulder? Where is it at there? Generalized. Size, right? So we're going to measure that out to see how big it is, right? If it's something that's small, like of a 1 centimeter, and it's the only thing, okay, well that's one location. Whereas if it's spreading out to like 10 centimeters, well hell, that's more generalized, that's more widespread. It's not just in one spot. Color, primary lesions, secondary lesions, special lesions, we're going to discuss what those things are. Again, there we go with that distribution, configuration, and palpation. Ruler, yay. Color-wise, so description, erythematous, necrotic, cyanotic, hyperpigmented, violaceous, hypopigmented, green, yellow. Basically, that is just breaking them down into how they look, right? So if I have a black widow bite, then my lesion could look necrotic, right? Because that's like it's dead. It's it's going away. If I was at the Oscars and Will Smith slapped me in my cheek, then that could be erythematous, right? It's red. That's what it is. So that's just how we break that stuff down. Inspect all skin. Y'all will do this once y'all get into your derm rotation, where you see individuals for their surface area evaluation. That's basically looking everywhere. Just because you go see a dermatologist because you've got something that's on your wrist, that specialist should look everywhere to see if it's not spreading, if it's not out somewhere that you haven't seen it, because it's on your mid-back, or it's on your ass, or it's on the bottom of a foot, and you haven't ever taken off your shoes or socks or yada yada. So that's what we're talking about. Again, not only are we looking at all of that skin, but we're getting into the hair, the nails, the mucus, genital, anal regions, right? Anyways, you'll see those things. Again, talk about solitary, multiple, is it localized, is it generalized? We're just looking for those things out there. So, again, we see those distribution of patterns, right? Unilateral, bilateral, symmetrical, asymmetrical, right? So it's only on one side, right? Again, these are all things that I'm going to be breaking down and specifying key components to every disorder that if you see it on a test question, you might know that is only happens with this one. That only happens with that one, back and forth. Okay? Distribution-wise, solitary lesion, okay? That one, yeah, we're thinking referral to derm for that because of the fact that that could be some type of a cancerous melanoma because of the color changes, the size, it's not symmetrical, it's not that kind of stuff. But again, that's a solitary lesion, that's only there. If you're an old man and have never worn a hat and bald, then you can have it generalized, you can have it, multiple lesions distribution. So he's got it all over that up there, okay? Again, multiple lesions, localized specifically to the forearms, whereas generalized, that's on the arms, the chest, the abdomen, the neck. It's, all over the place. Y'all know that we specifically, y'all are experts on all of the dermatomes. Y'all know where all of those things are at. They can be specific. This individual's having, what do y'all think it is? Shingles, right? So he's got that of the dermatome, so you only get that manifestation in that area only. And so that's the reason why you can see that. Distribution-wise, you can have it flexor, right? So flexor, that's oftentimes seen with some eczema, some of those things that's on of the arms, legs, da-da-da-da. You can have it extensor, so it's on the outside, so it's on those elbows or those kneecaps. I'm one of those who can actually show you all of these things because I have psoriasis, and that's what that picture is psoriasis right there. Intertriginous, so you see that is in upper or up and under of the breast. So that could be the breast, that could be the stomach, that could be the groin. Those are intertriginous areas that we can see with some of a fungal aspect. We can see with Pseudomonas. We can see that, you know, with obese, diabetes. Oftentimes we see these things located in those areas. Poison ivy, linear, right? That's contact that has happened at that area, and so that is the manifestation that it stays in that area. So linear. Annular, fungal, right? So we can see that ringed. We can see serpiginous. So you've got that of a wavy, creeping. We can see that with those there. And then that bottom picture, STI, you can say it. Clustered, grouped vesicles on an erythematous base. Y'all are infectious disease experts, so y'all know what that can happen. Again, talking more about that, right? So is it soft? Is it firm? We're going to go through some fibromas, right? So we've got a dermata fibroma with, if you pinch it, it dimples, right? So you can see something like that happens up. Compressible, tender, non-tender, are they trying to jump away from you because it's hurting so bad for you to even get into there? Again, gets into more of the breakdowns back and forth. And as I said, these disorders, diseases will have key components specifically to them that points you in that right direction. So, multiple small erythematous papules and vesicles located on the volar surface of bilateral forearms and antecubital fossa with excoriations and lichenification of the wrist bilaterally. So that's just breaking it down. That's you writing it as a dermatologist to describe it, okay? If it were me, I'd say, his forearms are fucked up. Okay? We're going to treat it that way. But that's the right way to say it. Okay, so now we're going to break it down into those primary, secondary, and then we're going to give examples of some of those special lesions out there, okay? So most of these skin diseases, it starts off with some type of a macule, of a this or that. It's that one spot, pityriasis rosea, that's that Christmas tree rash, right? It starts in one spot and then it spreads out like a Christmas tree. So that's what a primary lesion is. Identification of the primary lesion is key to an accurate interpretation and description of cutaneous diseases. So it gets that initial orientation. So this is where it starts and this is what it is now. Examples, like I said, macule, papule, plaque, nodule, pustule, vesicle, bulla, wheal. Those are all primary lesions. There's a macule, a y'all know my opinion. I don't mean circumcision, but I meant circumcised. Okay? Y'all know me. Flat discoloration, okay? A patch. So that is a macule that is greater than 1 centimeter. So these are specific definitions of what they are. So a patch is a macule greater than 1 centimeter. It becomes a papule if it's less than or equal to 0.5 centimeters in diameter. Plaque A circumcised, I said it again. Circumscribed. Why is it in my mind? We're not in that STI yet. So. Superficial, this one is greater than 5 centimeters in diameter. So that's when that plaque becomes a plaque. A papule becomes a plaque is because it gets over that 0.5 centimeters. So you can see some of that there. That is way more than 0.5 centimeters on that back. Psoriasis. A nodule, greater than 0.5 centimeters in diameter, but it is solid lesion. So it's solid. It's a large nodule. A tumor. Pustule, specific to this one, is that free fluid. So that's the pus that is with that being a pustule. Vesicle, grouped on erythematous base, chlamydia. Okay, so free fluid, less than or equal to 0.5 centimeters in diameter. Bola, again, greater than, and you've got that free fluid up and under. Wheal, so that's that hive. Again, we'll be getting into that once we get into some of our allergy contact dermatitis and stuff. So those are all of the primary ones. Those are those ones listed as primary lesions. Secondary lesions, they are brought about by modification of the primary lesion, either by the individual or the lesion, or through the natural evolution of the lesion in the environment, often created by scratching or infected. Examples, so you can have a scale, a crust, an erosion, an ulcer, a fissure, atrophy, a scar. Those are all the list of secondary lesions. So scales, again, lichen planus. You can see that with some of the psoriasis, right? So that's that dead epidermal cells that are produced by abnormal keratinization and shedding. Crust, that's that impetigo right there, okay? We see impetigo of our kiddos. Happens in those areas where there's that contact that has happened. So you start to get some of that crust that is there. A scab, cellular debris. Erosion, it's the focal loss of the epidermis, so they do not penetrate below the dermoepidermal junction, so that DEJ, therefore heal without scarring. So it'll go away and it'll look beautiful, but it's not going to leave a scar if it's an erosion. If it's an ulcer, that's going to stay there, okay? So here we got that focal loss of the epidermis and dermis. So ulcers heal with scarring, so that's how they are different. Fissure, linear loss of epidermis and dermis, sharply defined, nearly vertical walls. So you can see how it's talking about it being vertical. So that's that slit. So that's a fissure. Atrophy, that's that thinning of the epidermis or dermis, so that's that depression of the skin, so that's atrophy. Again, secondary, we'll talk about a lot of atrophy once we get into all of our UVA, UVB, UVC, all of that stuff. Scar, again, we got scars everywhere. So they can be because of some connective tissue implying dermal damage. So it's a damage. Something happened, whether that was some type of a treatment, surgery, wound. That would be causing us to have some of that. Okay, so that was primary, that was secondary, and now we're getting into the special. So this is talking about excoriation, comedone, so acne, right? Milia, cyst, burrow, lichenification, telangiectasia, petechia, purpura. So this is just breaking down what these special things are. These are not characterized as primary or secondary. It's just something special. Okay. Excoriation, erosion caused by scratching, often linear. So you can see where they are always scratching on of their arm, or they're always scratching somewhere that causes that to happen. So that would be excoriation. Again, that's just some more pictures of it. So back of the neck, da 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 da. Comedone. You know, we've seen all that with acne. So a plug of sebaceous and keratinous material lodged in the opening of a hair follicle. So that's that hair hole. We can have it black head, we can have it white head. So it just depends on what the process is progressing through. So that's a comedone. Milia, again, benign, asymptomatic, small, keratin cyst. Oftentimes we see that when the babies are born. We can see that on of their face. Eventually it's going to go away. But that's what milia is. You can have a cyst, okay, lesion with a wall and a lumen. So epidermal cyst, right? We have to not only take if there's fluid in there, if there's any pus, if there's any like thick stuff in there, not only do we take that stuff out, but we got to take that cyst wall all out, because if you leave it there, it's going to begin again. You got to get that cyst out. So we will talk about that. That individual has a lot of cysts in that area. Yeah. Burrow. So we talked about that with, you know, some of that viral stuff that can happen. We can have those of a channel produced by a parasite. Yes, we're going to go through all of the parasites. We're going to go through all of those, yeah, yada yada. Lichenification, so that's that thickened epidermis induced by scratching. So we're going to talk about that once we get into benign stuff. So we'll get into lichen simplex chronicus. We'll talk about lichen planus. We'll talk about these things to where individuals just always times just itch and itch and itch and itch and itch. So that's what causes them. Telangiectasia, so that is that superficial blood vessel. So that's the caps that are just, you know, have that blood showing, right? So you can see that with age, with atrophy, we can see that happen in those areas. That that lesion on of the right upper nose area, yeah, that's a BCC. That's a basal cell carcinoma, because that is one of those things that is oftentimes telangiectasia is associated with that. Again, this is all just throwing it out to y'all. We're going to get into all of these things specifically with the disorders they are associated with. This is just, you know, hey, Derm, da-da-da. This is the first chapter of the Bible. Petechia, that's less than what we're going to talk about next, because this one is less than or equal to 0.5 centimeters. Whereas purpura is greater than 0.5 centimeters. So, you know, one is less than, one is over. So y'all will know those things. Okay. Almost there, and we'll take a break. Differential diagnosis, okay? What is the most likely? What could it be? Okay? When it's dermatology, and y'all will see this as we get into of these disorders and as y'all are in phase 2 rotations, it could be something benign. We can think that it's something benign, but we're still going to test it. We're still going to put it through just to make sure it's not dead, okay? So that's why a differential diagnosis is It's always going to have cancer in it, okay? Because we're going to figure it out. We want to see what we think it is. So again, there you go. Yeah. Test biopsy. So we can shave it, we can punch it, we can excise it. So basically cut that damn thing out, okay? Again, y'all know, so it's about 3 weeks after our last test. It's after one of your surgery tests. We have what's of a derm and surgery lab in here, so we'll be bringing in some of the pig's feet, and y'all will be slicing and dicing and suturing and doing all of that kind of stuff with that. So y'all will get some practice there with those things, okay? Fungal stuff. We're always going to want to get some of the lab of that KOH so we can see that, okay? Skin scraping, gram stain, culture, cytology, so that zinc prep for herpes, that's a special test for that. Woods lamp, we're going to put the light on it and see, is it turning red? Is it staying the like normal color? Is it turning green, pseudomonas? Is it, you know, that's what we can do that. Patch testing, send them to allergy, and they're going to do that poke all over their back so that they can test against all of those things. Blood tests, RPR, CBC, ESR, HIV. So those are things. And dermoscopy, that's basically that small tool equipment that you can focus in. So it's almost like a telescope, but it's just used to look at those things. Again, we're going to talk about these individual disease chapters as we go through. Okay, we've got 4 categories. So we've got topical, which we're going to talk about next after this break. We have systemic, right? So we're taking some oral medications. Surgical, where we can put them into a phone booth that's got all of the color, all of the treatment-wise to do those things. Okay? Again, this was just of a basic breakdown of what we're going to get into, okay? If I were going to ask a question from this slide deck on a test, it's going to be probably comparing some of those measurements, some of those things that I threw out there to y'all, that it's this or this or this, okay? Less than or equal to, da-da-da, okay? All right, any questions so far? Okay, let's take a 10-minute break. We'll be paranoid stuff. So we're going to talk about how we do these things, a list of all of them, and yada yada. So we will get into that. Okay, we're tomorrow we'll start talking about some of the actual disorders. So we will start to be looking at a lot of specific pictures and everything like that, and from now on, when y'all are walking through HEB or something, you're going to see something and be like, I know what that is, right? My 15-year-old daughter, she's a volleyball libero, so we have her on a national team. And the tournament was this weekend. It was downtown at a convention center, Henry B. Gonzalez. There are thousands of people in there, and I walk around and I'm like, slide number 2. There you go. That's back and forth all around and all of that kind of stuff. This year we're going to Kansas City, we're going to Philly, we're going to Reno, and then of course it's always Houston and Dallas and Austin and all of that kind of stuff. So we travel around. All right. So topical therapy and topical corticosteroids. Like I said, again, Habib chapter 2 talks about the topical therapy of the corticosteroids. We're going to talk about their strength, right? So I'm going to talk about which of the groups those are. Groups are important. Vehicles are important because there are specific vehicles that are oftentimes used for specific conditions depending on what they are. Vehicle means how are they, or what are we giving them? A gel, a foam, ointment, you know, yada yada. Applications, adverse reactions, da 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 da. Okay. basically, if it's dry, wet it. If it's wet, dry it. Okay? So let's all bounce around back and forth. Okay? So the purpose of the topical therapy is to restore normal skin function after an insult removes water, lipids, or protein from the epidermis. So what is happening that is causing this to be dry, or it's causing it to have it be wet? Dry skin or dry cutaneous lesions. They have lost moisture, in most instances have lost epidermal lipids and proteins which help contain that moisture. Okay? So what are we going to do? Well, we're going to be using that moisture with emulsion creams and lotions and other things out there. So first let's talk about that dry skin. Xerosis cutis. Symptoms. Skin is rough, covered with fine white scales, progresses to thicker tan or brown scales. Okay? If it's severe, then you can get that crisscross and fissure. We know that fissure is that vertical lesion, a special lesion that could be happening, and that will happen if it is severe dry skin. Worse in dry winter months. Most common affects hands and lower legs. They'll have that itching and burning sensation. Treatment-wise, emollients, so 12% lactate lotion. So lachydrin, amlactin, those are just those lactate lotions that are out there. Again, why are we doing this? Is because we want to restore that water and lipids to the epidermis. So moisturize it. More that urea, lactic acid, those are those lotions that are out there, emollient. We can use some of those creams, but those are thicker and more lubricating than lotion, so it's more intense to get into that. Most effective when applied to damp skin. So after they get out of that shower, after they get out of that bath, don't take all of the water away. Pat it dry, but we want to have some of that moisture to help it get in there. And of course we want to apply it as frequently as necessary. Menthol and phenol can be added to reduce the itching. So that's like that stuff that just helps to take away some of that itch. So locations there. So that's that dry skin stuff. Emollients and lotions. Wet diseases. If it's wet, let's dry it. So exudative inflammatory disease leak serum. Leaches complex lipids and protein from that of the epidermis. So that is what that moisture, that's that wet is. Okay, managed with wet compresses. Suppresses that inflammation that is there. Debrides the crust and of the serum. Repeated cycles of wetting and drying eventually dry the lesion. Okay? Excessive use over dry. So let's not over dry. Let's dry it, but not over dry it. So we want to be doing, too much. Once wet phase is controlled, restore lipids and proteins with emollient creams and lotions. So just because we dried it all up, we don't want to, have it switch and flop into dry disease. So that's that things there that we still stick with those creams and lotions, but it's dry, so we don't need to be doing those wet dressings anymore. Of course, we're doing these benefit-wise is because we want that inflammation suppressed. So evaporate, cooling, construction of superficial vessels, decrease erythema, and serum production. Yes. Wound debridement, so we want to, have that. If it's got that vesicles or if it's got the crust, then we want to debride those things, take them away. Sometimes drying effect will work, but we could also need to use some type of an antibiotic if we do believe that there is an associated infectious process that is also causing you to have that wetness. So you can add that antibacterial action by adding that acetate, acid, nitrate, those things there. There's a list of those exudative skin diseases. Again, this is just listing it out. We're going to talk about all of these things. So, poison ivy, impetigo, eczema, simplex, bites, nummular eczema, stasis dermatitis, sunburn, tinea pedis, so foot disorder. Again, talked about that acetate, nitrate, acid, water. Talks about the preparation. So those are those wet dressings that are put on there. Not only do we put that solutions onto there, we also use some of that dressing. So 4 to 8 layers of clean, soft material, wet folded dressings in a solution. So oftentimes we just pad those things off and then wrap them up. Of course, once it's dry, then we don't have to do that anymore. So here you go. Look at that list. This goes on back and forth. Does it all of those creams and lotions and all of that stuff that breaks it down into percentages and stuff. That could be a damn crazy test question, huh? I'm not gonna do that, okay? I gotta stick with the groups. Know the groups. Know the groups. Group 1 is strong. Group 7 is weak. So for specific disorders, diseases, I will state what type of a group we will want, and that is what you will be tested on, is what group will be used. So this is just a list of all of those. Again, picture from Habib, the Bible, and all the way on the left of this list, you see groups. 1, 2, 3, 4, 5, 6, 7. So, the effects of the topical steroids here, of course, we know we need to reduce that inflammation. So it's anti-inflammation. It does do some of that vasoconstriction and anti-mitotic. So decrease proliferation of cells. So it reduces that keratinocytes. Keys to appropriate use. Well, of course, we know that we have the accurate diagnosis. We want to use the proper strength. We want to use the proper vehicle. Sufficient quantity, right? So FTU, fingertips. We are going to talk about that in a bit. And of course, we always have follow-up. So come back and see. Group 1s are the strongest. 7 is the weakest. 7s are all of those over-the-counter ones that you can pick up at Walmart, right? That's that hydrocortisone, it's those things that you can sell OTC, whereas the higher groups have to be prescribed. Choose the right strength for the right condition. No responses in 1 to 4 weeks, then we want to reevaluate. So basically, if I'm using a group 1 and nothing is happening at all, then I'm probably going to have to switch and go into something else, like what? Systemic, right? So I'm going to get into a biological medication, right? I take Otezla twice a day because of my psoriasis, because topical shit doesn't work. All right. Concentration, yeah. Talking about just breaking them down. Vehicle. Substance in which the active ingredient is dispersed. So how are we going to do that? We can give them a cream, ointments, gels, solutions and lotions, foams. These things have specific components that are necessary to be used. So a cream, that's that white color or slight greasy texture, slight greasy, okay? It's not like an ointment that is greasy, okay? This is slight greasy, but more, it's that white one, okay? High versatility, you can use it almost everywhere. So it doesn't matter if it's on your groin or if it's on the bottom of the feet or something like that. That's where we can use that. It works, but it can also cause some irritation. You can have some of the stinging, some of the allergy. Ulta loves it because it's cosmetically accurate, okay, acceptable. It'll have some of that drying effect with long use. Most useful for the intradermal areas, okay? Again, it says you can use it anywhere, but specific. If it's of the groin, of the rectal, axillary, a cream is oftentimes the first choice if you're treating something that is in those intravenous areas. So up and under the breast, of the abdomen, of the groin, those areas, that is cream. Ointment, primarily grease, right? It is grease, okay? Typical preservative-free, translucent, that greasy feeling on the skin. Most lipophilic, moisturizing, and occlusive. So if we're using some ointment, we want to always use that because it's greasy in some areas that we can have some of that stuff to cover it up, right? So you're not getting all of this grease into your blankets and sheets and clothes and all of that other stuff. I have clobetasol ointment that I use for my psoriasis, and if I do it at night after shower, and then I put on a long sleeve shirt, pants, so that I don't spread it all over the place. So that's why if it is some type of ointment, then occlusive is a key component of it. Greater penetration and increased potency. So yes, I told y'all my psoriasis is not bueno, and so that's why I use ointment, just because of the fact that it is most effective with all of the itchiness. Too occlusive or accurate, again, is exactly what I said. Eczematous inflammation, intravenous area. A gel. Proline glycol, water, okay? Sometimes it can have some of that alcohol into it. It's greaseless, it's clear, it's jelly-like, okay? Yeah, jelly-like. Thank you for getting. Useful for acute exudative inflammation, right? So we'll use a gel if it's some type of a poison ivy. It's useful of the scalp. So if you're seeing something specifically related to the scalp, then it won't mat the hair. So it's like a gel, okay? So you would put that up there. Up next, we've got solution, lotion, right? So we've got that clear or milky, least lipophilic, can be very drying, most useful in the scalp. So just like that gel, if it's a scalp, then we can use this in the hair. Again, it shows on there that if you were to use this in that intravenous areas, then that can cause some of the stinging and drying. So oftentimes this is not going into those areas. Foam. Do not use greater than 2 weeks. Do not use if age less than 12 years. So if you're a child less than 12 years old, do not pick foam. Foam is not there. Foam is useful for scalp dermatosis, useful in areas of acute eczematous inflammation, right? So plaque psoriasis, poison ivy, okay? It is high potency preparation. That's why we don't give it to kids. Kids have that young, healthy skin, right? They've got that good stuff, whereas as old people, it's all thick and yeah. You can use this stuff on an adult, okay? Again, we're not using a foam for greater than 2 weeks. We're not going to use it of a less than 12 years old. And we want to, you know, if this is not pituitary, hypothalamus, if it's not those things, then we would, yeah, that would suppress it, and we don't want that. Talked earlier about that ointment, how we can do some occlusion, right? So waterproof cover enhances absorption. So we wrap it up so that it's not spreading and it can actually get into that. I told y'all how I will wear a long shirt, pants, that kind of stuff, but sometimes if it's getting really, really severe on my hands, I will put it on and then I'll put my hands in gloves and just cover it up for an hour or two. That's occlusive, okay? But my hands look beautiful today, so I don't have to. Remember, even hydrocortisone under diaper can cause adrenal suppression in an infant. So, okay, that's just one of those things. Saran wrap. I don't know if any of y'all ever go to the gym and spend time inside of a sauna, but there are some people who will wear that stuff in sauna. It's like, damn, pass out. Topical steroid therapy, hydration, okay? So we need to make sure not only are you putting stuff on it, but we're going to have you hydrate as well. Steroid application, talked about how that's best when the skin is a little bit moist when you use that. Regional differences, thin stratum corneum and increased blood flow, increased absorption, so of the face and the eyelids. Decreased absorption due to thicker stratum corneum, so the soles and of the palms. Okay, it just depends where you're using this at, indicates what vehicle you should use, what group you should use, like how is the skin at that time. Adverse effects. So this is why we do follow-ups, why we give them plans, we give them methods of when and how and, you know, to do it, because if they're overusing it or if they're on it for too long, then it can actually cause some of the side effects, right? So burning and itching, hypopigmentation, that's just having that skin turn white, right? Atrophy, so it's almost like scarring, it's almost like it's thinning out that area. Striae, you can see those marks on areas that we will see here. Hypertrichosis, folliculitis, steroid rosacea, so that's that malar rash that's on the upper cheeks. Dryness, worsening infection, rebound, phenomenon, da-da-da-da. We're going to say phenomenon a lot. I like it. So there's that hypopigmentation. We can see that axilla area there. It's that light skin of this face. That light skin. That atrophy. So it's thinning of the skin. Telangiectasis. So you've got that caps that are there. That's a wonderful nose piercing. Atrophy and bruising. Talk about that striae. So it's that thinning marks oftentimes that is seen with obesity. Infectious process, so we start to get some of that folliculitis, acne, as seen there. A smile that will never go away. Steroid rosacea. So that's that. Another thing is you can have that some type of a contact allergy. So it's a response. So you have never tested if they have allergy to a specific type of a medication. That's why we send them to allergy clinic to go get all of the testing done. So you can see, you know, some of that allergy that is out there. Non-specific self-supporting eczematous condition, so that eczema, xanthan, purpura, urticaria, so it itches. Again, patch testing as is seen there. So they put those things on all of your back, and each one is a specific location to a type of an allergy. We can also get some systemic adverse effects, right? So if we're doing topical steroid therapy, then we need to make sure that we're checking of the thyroid, of adrenal axis that we can see, right? If it's of a child or if it's a teen, they could get some type of that Cushing syndrome. Failure to thrive, stunted growth, cataracts, glaucoma. My daughter, she's 15, and ever since she was a baby, she's had what y'all could have already talked about, but you will have, peds definitely have it, but there's that triad of allergies, eczema, and asthma that are usually put together. Well, she, started that when she was young, and so she's been on topical steroids and other things like that. So she's the same height as her damn mom. That's 4'11". So that's why she is a libero in volleyball, because she doesn't jump up and spike it and do all of that kind of stuff. But she's got some of that stunted growth. She, her older sister is my height, but she's down there with her mama, as she texts me. Other methods, right? So we know that we've got some of an intralesional, right? So we're injecting some of the steroids into that. We can do that, right? If the topical stuff isn't working, then we can do intralesional. We can do IM. We can do those other things that are out there, okay? But again, those have adverse side effects as well. So intralesional, dilute, depending on what that strength is, how that works. IM, if we're having some of that injection into that muscle, then we can have some of that atrophy that does occur. The five most common mistakes. Steroid too weak for condition and area involved, so you don't get it strong enough. Okay? Not enough medication given, right? Tube size. If I know that mine is almost up, I'm calling that damn thing into the VA to send it on over, because I don't want it to go away. Failure to follow up on the treatment, so you're not bringing them back to check on them. It's too strong up to kids, too strong up the face, right? Those are things. So the bottom line, use the right potency, the right steroid, the right vehicle, the right location, and the right duration. So it's breaking it down into all of those things. And again, once we get into disorders beginning tomorrow, I'm going to specific state we use this medication that long, this and this and this. So I'm going to break them down so y'all are going to know what those are. FTU, fingertip units. Key component right here. 1 FTU is half a gram, 0.5 gram. So if I have you to calculate how much an FTU is, then you know 1 FTU is half of a gram. Rule of the hand, okay? One-handed area. So of the palm, one hand is usually 1% TDSA. So one hand, okay? So depending on its that, as you see here, it breaks it down and it talks about face and neck, 2.5 FTU. Of the trunk of the front, so that's 7 FTUs back. If it's both of those added, then that goes up to 14, right? So that's just breaking it down into where those areas are. That is for adult FTU reference. Child, of course, that depends on its age. Okay, their size. It's not going to be the exact same thing. I'm not going to treat a 12-year-old the same amount of an infant, right? It's not the same. So that just breaks it down. Okay? Again, testing wise, I will stick with 1 FTU equals what?
0.5.
0.5 gram, okay? That is what I get into. All of this other kind of stuff, yeah. No more than 40 to 60 grams of group 1 agent per week, right? Group 1, because that's the strongest. Apply group 1 agents once a day or twice a day. 2 weeks on, 1 week off. So it just avoids of the tacky stuff, okay? Group 2 through 7, basically BID times 2 to 6 weeks. So that just breaks it down. Again, I am key on the groups, not specifically you picking clobetasol versus, yeah, not that stuff. Groups are what are important when it comes to the topical stuff. Okay? All right. Any questions? Okay. Tomorrow we will be here at the same time, 10 o'clock, and I think I'm getting